Next, I'll call upon Dr. Apsara to present her paper on retinal capillary macroaneurysm diabetic macular edema.
Good afternoon all. Our paper is on retinal capillary macroaneurysm in chronic diabetic macular edema, response to various treatment modalities. Diabetic maculopathy is most common cause of visual impairment in diabetic patients. The chronic diabetic macular edema is defined as macular edema persisting for more than 6 months without any treatment or more than or equal to 6 months even with anti-VEGF therapy. We all know that microaneurysms are most common and initial finding in diabetic retinopathy with a size smaller than 100 microns. The large aneurysmal dilatation of retinal capillaries are called retinal capillary macroaneurysm or RCMA, with a size ranging from 100 to 300 microns, which leaks and cause refractory macular edema. This study is to assess the efficacy of various treatment modalities for retinal capillary macroaneurysm in chronic diabetic macular edema with respect to visual acuity, central foveal thickness, and size of retinal capillary macroaneurysm. It's a prospective study conducted in 50 eyes of 39 patients from January 2023 to March 2024. The patients with RCMA in diabetic macular edema treated with either intravitreal pharmacotherapy, either anti-VEGF or dexamethasone implant with or without focal laser photocoagulation. The patients were assigned to different treatment based on their response to any previous treatment and location of macroaneurysm, whether it is center involving or not. The macroaneurysm within 500 microns of foveal center are excluded from focal laser. The retreatment was given in case of recurrence of edema during follow-up, and the injections were given on PRN basis. The data analyzed are logMAR visual acuity, central foveal thickness in microns, and size of retinal capillary macroaneurysm in microns at baseline, 3 months and 6 months. The central foveal thickness and size of RCMA were measured using manual caliper tool in STOCT Heidelberg Spectralis. The study group include RCMA of size greater than 100 microns and located within the arcade. Both treatment naive and newly treated patients were included. The aneurysm of size smaller than 100 microns and those present at or beyond arcade were excluded, and other retinal vascular diseases were excluded. In our study, 80% of the patient received intravitreal pharmacotherapy, out of which 54 patients received pharmacotherapy alone and 46 received focal laser with or without pharmacotherapy. Average number of anti-VEGF received during the study period is 2.06 and dexamethasone implant was 1.16. And 36% of the study group had single RCMA and 64% had multiple RCMA. At the end of 6 months, the visual acuity stabilized in all groups except anti-VEGF monotherapy group. Similarly, as visual acuity, the central foveal thickness reduced in all groups except anti-VEGF monotherapy group. The RCMA size responds very minimal with anti-VEGF monotherapy, and it responds well when laser alone or in combination with pharmacotherapy given. This is the pre and post treatment picture. The second picture showing regression of RCMA following direct focal laser. This is pre and post treatment picture. The second picture showing resolution of edema and involution of RCMA following intravitreal dexamethasone and focal laser. Our study is the largest study on RCMA in chronic diabetic macular edema, and we also compared the response of various treatment modalities including the combination therapy of focal laser with intravitreal pharmacotherapy, and we documented the good response of laser with respect to stabilization of visual acuity and macular edema. According to Spade et al., the rapid resolution of edema and involution of aneurysm was shown with laser. Spade et al. Found that RCMA is an important biomarker in diabetic retinopathy which may not respond to intravitreal anti-VEGF and steroid and respond well to focal laser. Sagar et al. Showed that the DME secondary to large capillary aneurysm respond well to targeted laser. Pakis et al. Showed that the chronic DME refractory to anti-VEGF had better anatomical and functional outcome following focal laser. Thus, we conclude that detecting retinal capillary macroaneurysm in chronic diabetic macular edema is essential for customizing treatment approaches in patients. The retinal capillary macroaneurysm show poor response to anti-VEGF therapy, and whereas it responds well to targeted focal laser. However, only less than 50% of the lesions are amenable to focal laser because of its proximity to fovea. So, in remaining 50% lesion, the intravitreal dexamethasone implant is better option than anti-VEGF. We also found that diabetic macular edema secondary to RCMA also shows sustained response to combination therapy of focal laser with intravitreal pharmacotherapy. These are my references. Thank you.